Why it is written IMA Mumbai there, Manish?
Sorry, sir.
IMA Mumbai. How it is? It should be IMA Mumbai West. Aparna?
So I'll get them to
Sir.
I'll get them to change it.
So, Dr. Rashmi, we are live. You're good to go.
All right. Good afternoon, everybody. A very warm welcome to the special webinar on GERD, gastroesophageal reflux disease. Gas or acidity is a very common complaint of all patients who come to the OPD, whether it is a family physician or a specialist. However, GERD is something very, very different. It has to be quantified. It can present with a wide varying symptoms. And we have two experts who are going to guide you in this today in this special webinar. And I would like to hand over to Dr. Shobha Ahuja, Madam President, IMA Mumbai West, to say a few words.
Dr. Shobha? Where is she?
The moderator for today's session is Dr. Jayesh Lele, Senior National Vice President, IMA Headquarters, and he is going to introduce the speakers. Dr. Shobha, Madam?
I think she's on that iPhone. I don't know.
She seems to have, she was there just now. She seems to have logged out.
There seems to be some connection problem, ma'am.
Lele sir, can you start when Madam logs in? We can ask her to say.
Yeah, we will have a word with first of all, thank you, Dr. Manish, Dr. Gulshan.
Hello.
Yeah, Shobha, please join.
Yeah.
Yeah, your connection issue is there. Yeah, you can speak, please.
Hello.
Yeah.
Good afternoon. Good afternoon, and I welcome you all to today's webinar. The IMA Mumbai West has organized this program, specially considering the gastritis and a slight cough that is so very common, mainly in senior citizens. They tend to either eat absolutely no chilies diet or tend to pop in PPI or H2 blockers at random. But today we shall highlight the GERD, G-E-R-D, and comorbid conditions, followed by different patient profile, giving you the practical picture with safety of proton pump inhibitors. And all this is by the eminent doctors, Dr. Ketan Mehta sir and Dr. Molina Khanna. You can also ask any queries you have regarding this. Let us proceed with the webinar. Over to you, Dr. Rashmi Mehta.
Thank you, Madam. Thank you for those kind words. And I would like to ask Dr. Jayesh Lele sir, moderator for today's session, to take over. Dr. Lele is the Senior National Vice President, IMA Headquarters, and the leading light, a beacon of light for IMA Mumbai West. He has arranged this conference for IMA Mumbai West, and he's going to be moderating the session. Over to you, sir.
Yeah, thank you, Rashmi. And first of all, let me thank Dr. Manish and Dr. Gulshan, because I have been talking to Dr. Manish for a couple of times for arranging this special webinar, which is in fact in live telecasted across India. So a lot of other delegates are there, and this is our faculty link. So that's why we are not in a position. But yes, definitely, as Dr. Shobha and Dr. Rashmi mentioned, GERD is a very important topic day to day. For a flight from family physician to the senior consultant, they always come across this issue. And nowadays, we see commonly not only with the medicines, but with the food and other things. GERD is so common that we day to day, almost 50% of the patients, we need to think at the back of the mind about the GERD issue. And today we have with us Dr. Ketan Mehta as a family consulting physician, and Dr. Molina Khanda, who is a gastroenterologist in the western suburb. They are a proud member of the IMA Mumbai West, and definitely we would be very happy to listen to them. Dr. Molina Khanna would be talking especially the diagnostic portion for the GERD and the PPI is important thing. And Dr. Ketan Mehta would be talking about the managing the comorbid conditions. So let us start the program with Dr. Molina Khanna. She's a leading gastroenterologist practicing in Western suburb for years together, and definitely she has made a very impact on a lot of patients, and her sound knowledge. She has taken very important talks also in our IMA Mumbai West and at various fields. She is a project coordinator for Jeevan Prakash. She is an integral part of the team, assuming the roles of organizing, editing, and troubleshooting in many projects. She is an active advocacy of organ donation also, and she's a proud parent of the daughter and physician. Her son recently passed MD, and he will also be joining and looking after some super specialty later on. So before wasting any time, I would request Dr. Molina to start the talk. Dr. Manish, I think you'll have to give her the hosting so that she can have her presentation. Over to you, Dr. Molina. Please go ahead.
Thank you, Dr. Jayesh Lele, for those kind words. Can I share my screen now?
Yeah, ma'am, you can share.
Just give me a moment. I'm opening my presentation. So today we'll be talking on gastroesophageal reflux disease. Yeah. So we're talking on gastroesophageal reflux disease and comorbid conditions. So first, some clarity about the terms. What is GERD? Gastroesophageal reflux disease is an umbrella term which includes both the symptoms as well as the investigations and treatment of any disease, of a disease which is caused by reflux of acid from the stomach into the esophagus. While reflux esophagitis is a small part of GERD, because less than 50% of patients of GERD will have reflux esophagitis as seen on endoscopy. And therefore, the rest of the patients will be called as non-erosive or endoscopy negative GERD. Then there is another term which is called as acid-sensitive esophagus. Acid-sensitive esophagus means the amount of reflux which happens into the esophagus is physiological amount, but the patient's esophagus is extra sensitive and therefore they will get symptoms. So it is one of the most prevalent conditions, as you've just heard from our Dr. Lele and Dr. Ahuja. And it was found to be about 10 to 20% in the Western world and less than 5% in Asia. Heartburn in the general population is seen to the tune of 7 to 15%. But as I've already mentioned, esophagitis is present in GERD in only 20 to 45%. Now, what is Barrett's metaplasia? Barrett's metaplasia is a complication of gastroesophageal reflux disease where the esophagus lining gets converted to a gastric lining. That means the squamous epithelium converts itself into a columnar epithelium. And why is it important? Because patients with Barrett's metaplasia can go on to develop adenocarcinoma of the esophagus. So this is, but unfortunately, unless you do an endoscopy, it does not get diagnosed. So in fact, varus metaplasia could remain undetected in almost 5/6 of the patients. And the male to female ratio of patients of GERD is roughly equal, but esophagitis is more often seen in patients, in males as compared to females, probably because they have more severe disease. And while Barrett's esophagus is seen more often, much more often in males, 10 times more in fact, as compared to females. So what we have to remember is that some degree of reflux is normal, what we call as physiological. First is postprandial, that is immediately after a heavy meal especially, some amount of reflux can happen. But this reflux is generally short-lived and asymptomatic, and it rarely ever occurs during sleep. So how does this disease happen? That is how the GERD happens because of one excessive number of reflux events. That is, more amount of reflux is happening throughout the day. More number of times it is refluxing up, or the amount of time that the reflux stays inside is higher. So the excess number of reflux events. Second is a prolonged acid clearance. Now what happens once the reflux comes in, our esophagus clears it off quickly by peristalsis, by saliva, neutralizes it. So this acid clearance doesn't happen in a normal manner. It gets prolonged, and hence you get GERD. And the mucosal resistance of the esophagus, the inherent mucosal resistance of the esophagus is impaired, and that is why a patient develops the disease. So what are the mechanisms of reflux? One is what we call as a transient lower esophageal sphincter relaxation. That means the lower esophageal sphincter relaxes from time to time for a very short period of time. And this happens normally. In fact, it happens in everybody. And in fact, that is the way most people will belch. But belching is just air coming out, while in reflux or in regurgitation, some amount of stomach content also comes up to the throat. So if the transient relaxations are more in number, then again reflux happens. Then if the lower esophageal sphincter is hypotensive, normal tension is about 10 to 30 mm. If it is hypotension, then again it is more liable to for the reflux to happen. And hiatus hernia, we'll talk about it here. So hiatus hernia is basically that the diaphragmatic sphincter doesn't work as well. So that is why part of the stomach goes up into the thorax. And this is because leads to increased susceptibility to sudden increases in intra-abdominal pressure profile. Then pregnancy. Pregnancy again is liable to develop GERD, because one thing is the progesterone, that is the hormones, the effect of hormones decreases the LVS pressure. And secondly, mechanical factors, that means increase intra-abdominal pressure, which happens because of the increasing uterus. Then obesity itself can have a high risk of GERD because of increased intra-abdominal pressures and various other mechanisms which are not very clearly understood. Then certain medications can cause GERD. One of the classical examples which I like to give is calcium channel blockers. Many of our patients will have hypertension as well as GERD because both of them are lifestyle diseases to some extent. So many of our patients are on calcium channel blockers, and in these patients, sometimes GERD will get aggravated because of the loosening of the lower esophageal sphincter. Then smoking. Again, smoking reduces the lower esophageal sphincter, and alcohol also causes more GERDs to happen. So as I mentioned about the transient LES relaxations, the frequency may not be increased in GERD, but the frequency of the acid reflux is increased. And fat increases the frequency, and drugs like baclofen decrease the frequency. That is why in very rare cases in which GERD does not respond to routine treatment, you may sometimes give the patient baclofen. Then LES pressure, the resting tone, as I mentioned, is 10 to 30 millimeters of mercury. But whenever there is an increase in the intra-abdominal pressure or a gastric distension, all this can affect the LES pressure. Then strain-induced reflux and free reflux always will occur in patients with decreased LES pressure. But it is important to remember that only a minority of GERD patients have a low LES pressure. Majority of them have a normal LES pressure. It probably decreases periodically in patients. So hiatus hernia, the size of the hiatus hernia is important. It correlates with the susceptibility to strain-induced reflux, and the hiatus hernia affects the LES pressure too, and also increases the frequency of transient LES relaxations. Then delayed gastric emptying. It is seen in only a small fraction of patients, but delayed gastric emptying causes again more promotion of GERD because of the increased gastric pressure. But it is only a potential cofactor in exacerbating GERD rather than a cause of GERD. Then tissue resistance, that is the resistance of the esophageal lining. Because acid and pepsin, when it comes up into the esophagus, both are responsible for the loss of epithelial defense. Okay, now we come to what are the symptoms, typical symptoms of GERD. The three important symptoms, I would say: heartburn, regurgitation, and chest pain. Heartburn is again one of the commonest symptoms. It is intermittent. More often it is postprandial. It is induced by sleeping when you're in a horizontal position. And in exercise, why? Because whenever you do exercise, which increases the intra-abdominal pressure, again, GERD is promoted, and that is why you will get heartburn. Similarly, regurgitation is seen more often in patients when they are bending or if they during belching, and whenever there is an increased intra-abdominal pressure, especially when you're wearing tight fitting clothes, etc. Then another important part is the chest pain. Sometimes patients can develop only chest pain. I will talk about it a little bit later in the later slide. So I'm not detailing it right now. Then the other thing is dysphagia. This is more often seen in long-standing disease. And this can happen, one thing is because of the inflammation. Secondly, because of stricture which happens, which is called as a peptic stricture, or sometimes because of the peristaltic dysfunction. That means the normal peristalsis of the esophagus is required for the normal swallowing. And if there is an impaired peristaltic dysfunction, again, patient can get dysphagia. Then there is something what is called as water brush. So what is water brush? It is excessive salivation. So this is a reflux. This is actually a reflex, because excessive salivation will help in neutralizing the acid which has come up. So patients will have water brush sensation. Then globus sensation. What is globus sensation? Globus sensation is a feeling of a lump in the throat, which may not be related to eating. It may be present all throughout the day or at certain parts of the day, not related to meals, etc. Now, globus sensation was initially thought because that this could be because of reflux disease, but now we are not terribly sure whether globus sensation is caused by reflux. Globus sensation could be what we call as a various gut-brain disorders, various digestive gut-brain disorders. So this may be part of that. Then odynophagia, that is painful swallowing. Again, that is not very commonly seen in patients with reflux. It can happen only if there is significant a large ulcer or something like that. Then nausea, again, is not a typical symptom of GERD, but in a lot of patients with GERD, nausea will be present. So now let me talk a little bit about chest pain in gastroesophageal reflux disease. One, it mimics angina pectoris, and it is very important to know this. Why? Because angina pectoris or ischemic heart disease is a life-threatening disease. If you miss diagnosing GERD, it is not going to be too much of a problem. But if you miss diagnosing angina or IHT, it can be life-threatening for the patient. So you should always keep this in mind, that whenever there is chest pain, which you think it is GERD, whether this is part of angina pectoris or ischemic heart disease. Because the pain is again very similar, squeezing type of a pain, burning type of a pain in both the cases. Then It is located in patients of reflux disease. It is located substernally and radiating to the back, neck, jaw, arms. Again, this is so typical of angina pectoris. And it lasts anywhere from minutes to hours, and it can either resolve spontaneously or with antacids. Then it usually occurs after meals. Again, as we all know, angina pectoris can happen after exercise or sometimes after meals. So again, it can be difficult to distinguish. Then it awakens patients from sleep because, as I mentioned, sleep, when you're in a horizontal position, there is more liability for the stomach contents to go up the esophagus. Therefore, the chest pain can happen during sleep. It can be exacerbated by emotional stress. And sometimes you may have only chest pain and other symptoms of reflux may be absent. So these were all the typical symptoms which I mentioned, but there are certain atypical symptoms in GERD. So one of them is posterior laryngitis. Posterior laryngitis can give rise to hoarseness of voice. Then, so these are atypical symptoms, and they're atypical because they are not very commonly seen in patients with GERD, but you should keep this in mind. And whenever you come across a patient of, say, sore throat, then there is an association between asthma and GERD. And probably it is only an association. There is no causal relationship. But initially it was thought that it could be causal because it could be aspiration of the material which has come up into the esophagus, into the larynx, or it could be a reflux bronchoconstriction which happens because of vagal stimulation, because of the acid in the esophagus. So, and the third thing, important thing is chronic cough. There are three important reasons for chronic cough. One is GERD, second is a post-nasal drip, and third is asthma. So chronic cough is seen in about 10 to 40% of the patients of chronic cough. It could be due to GERD. But you have to keep the other reasons of chronic cough also in mind. So what is the natural history of GERD? There is no consistent relationship. Basically, you have to remember that between the disease severity and the duration of symptoms. A patient could come to you with 15 days symptoms, and if you do an endoscopy, he could have a severe esophagitis, or sometimes the patient is having symptoms for a very long period of time. And when you do an endoscopy, there is no esophagitis. So the disease severity and the duration of symptoms, there is no consistent relationship. Now, a patient who has developed erosive esophagitis and who has been treated, there is a chance of 80% recurrence in 3 months, especially in patients who have a more severe degree. You know, you have A, B, C, and D. These are the grades of esophagitis, where A is the least and B is the most. So patients with, say, C and D esophagitis, they are severe esophagitis, they are more likely to have recurrence after stopping the treatment, and more likely that these patients will require treatment for a long period of time. Then peptic stricture is seen in about 8 to 20% of patients who have developed esophagitis. Then bleeding, perforation complications are rare. So what are the complications of GERD? One thing is esophageal ulcers can develop. Then sometimes these ulcers could bleed, and therefore there could be hemorrhage. They develop what we call a peptic stricture, and that can give rise to dysphagia, etc. In fact, sometimes you may need to dilate the strictures also. Then what I've already mentioned earlier, what is called as Barrett's esophagus, where the lining of the esophagus gets converted from a squamous to a columnar lining. Then there is rarely perforation can occur. And again, rarely esophageal adenocarcinoma can happen. And this happens more often in patients who have developed Barrett's esophagus. And therefore, you may need to monitor these patients who have developed Barrett's esophagus by doing screening or screening endoscopies. So what is the differential diagnosis of GERD? First of all, there could be other causes of esophagitis. One thing could be infective esophagitis. The common which you see is candidal esophagitis, especially in patients who are diabetics. Diabetics are known to have candidal esophagitis. Then drug-induced. Drug-induced, the most common drug which I have seen in my practice is doxycycline. In fact, 9 out of 10 patients of drug-induced esophagitis, or what you call as pill esophagitis, have been because of doxycycline. So that doesn't mean that you should stop giving doxycycline to the patient, but it is important that whenever you give doxycycline to the patient, you tell your patient that this drug has to be taken with a lot of water, and don't sleep immediately after taking the drug. So if you take sometimes what happens, the capsule remains at the lower end of the esophagus and it doesn't go down, and then that causes the esophagitis. So if you take it with a lot of water, this can be totally prevented. So these are other causes of esophagitis. Then what are the other differential diagnoses? One thing is peptic ulcer disease. So it could be duodenal ulcer disease, or it could be gastric ulcer disease, because the symptoms, dyspeptic symptoms, abdominal pain, epigastric pain, retrosternal pain, and nausea, vomiting, these are common in both GERD as well as ulcer disease. Then gastric carcinomas. So gastric carcinomas also can have similar symptoms. So this could be one of the differential diagnoses. Gallstone disease has dyspeptic symptoms, and therefore that also has to be kept in mind. Then I have already talked to you about coronary artery disease. As I mentioned earlier, if the patient has predominant chest pain or predominant retrosternal discomfort, you have to keep coronary artery disease in mind, whether it is a young patient or an old patient, because we are definitely seeing a lot of young patients with ischemic heart disease. And you should never miss the ischemic heart disease or label a patient of GERD without definitely ruling it out. Then finally, what we call as esophageal motility disorders. Esophageal motility disorders, that means the functioning of the esophagus, the proper peristalsis doesn't happen and things like that. So these patients can also have developed similar symptoms like dysphagia, chest pain, etc. So that is another differential diagnosis. So how would you evaluate a patient with GERD? First is endoscopy. So why do we do endoscopy? One thing is for diagnosis of disease. But of course, as I mentioned earlier, it is a very very high specificity, but a very low sensitivity. Less than 50% of patients with GERD will have positive findings on endoscopy, because the rest are what we call as NERD. It is non-erosive reflux disease. So endoscopy is used for diagnosis, and it is also used for detecting and managing complications. Which are those complications? These are like peptic stricture, Barrett's esophagus, etc. Then barium swallow is useful mainly in patients with dysphagia, and it is not generally done as a diagnostic tool for GERD. But whenever you are in a dilemma, you're not sure if the patient has significant dysphagia, and sometimes what happens is there is a peptic stricture, then and the scope does not go beyond it, then you may have to do a barium swallow to see the extent of the stricture so as to plan the treatment of the stricture. Then you have what we call as 24-hour pH monitoring. So it is a topic by itself. I will have all diagnostic criteria and things like that. But I will not go into too much of details, except for the fact that a monitor is kept inside a 24-hour pH monitoring. You have a tube with a monitor is kept inside the esophagus at a particular level, and it is kept, the patient continues his day-to-day work or continues to do whatever he does every day for 24 hours. And then there is a monitor, there's monitoring of the acidity in the esophagus. So how much time the pH goes down. If the pH goes down for a significant number of time, for example, if it goes down for more than 4% of the 24 hours time, then this is probably possibility of GERD. Then another important thing is what we call as a therapeutic trial. So you may or may not, especially in patients with shorter history, you may or may not do all the previous investigations. But if a patient has a typical history of regurgitation and heartburn, you may just give a therapeutic trial for about 1 to 2 weeks with PPIs, and they respond well, and that's how you diagnose GERD. Then we'll come to that a little bit later in the treatment part. Then esophageal manometry. Esophageal manometry is basically only to monitor the musculature of the esophagus. How much is the esophagus peristalsis? How is the peristalsis going? So, but it is useful only in patients. If you have to do the 24-hour pH monitoring, you have to place the pH probe 5 centimeters above the lower esophageal sphincter. So if you have to see where is the lower esophageal sphincter, you need to do a esophageal manometry. So before 24-hour pH monitoring, sometimes you need to do a esophageal manometry. Then we'll come to both these things later in the next slide. Then sonography of the abdomen. Sonography of the abdomen is important in all patients of epigastric pain to rule out other causes of pain like gallstone disease, pancreatic disease, etc. Then secondly, as I've mentioned, I cannot stress this more, cardiac evaluation if the chest pain is a significant part of the symptoms. So this is a barium esophagogram. It's a well-tolerated test, but it is non-specific for the diagnosis. In the early stages of reflux esophagitis, you could see a granular or nodular appearance of the mucosa. Then there could be shallow ulcers or erosions which can be recognized. But its utility is mainly in patients with dysphagia, to look at any webs or strictures or if there is any malignancy, etc. So endoscopy, this is the Barrett's metaplasia. See, here I can say that this light pink mucosa is the esophageal mucosa, while this mucosa, the dark mucosa, is a gastric mucosa. Normally, and this is the GE junction. Normally, for about 1 to 2 centimeters above this GE junction, you have a pinkish mucosa. But here you can see this pink mucosa is extending above also. So this is what we call as a Barrett's metaplasia. If you take biopsies from here, you will find that there is, though this is the esophagus, so that means it should be a squamous epithelium, that you don't find the squamous epithelium, but you find the columnar epithelium. So what do you see on histopathology? If you take a biopsy, you will see reactive epithelial changes, inflammatory cell infiltration, or Barrett's metaplasia. Again, this is an example of Barrett's esophagus. You can see that again the dark pink is extending much higher into the esophagus. Again, this is another view. So let me talk a little bit of ambulatory pH monitoring and manometry, because both these are available in Mumbai and in big cities of India, and in the bigger hospitals. In the gastroenterology department of the bigger hospitals, ambulatory pH monitoring as well as manometry is done regularly. So when do we need to send patients? One thing is if you have to confirm the GRD in those patients with persistent symptoms, but a normal endoscopy, and their trial of twice daily PPI has failed. So you're not sure what is the diagnosis. So in those cases, for diagnosis, you will need to do this ambulatory pH monitoring. Then you have to, it is useful to monitor the adequacy of treatment in those with continued symptoms. Then if you want to send any patient for anti-reflux surgery, then again, you have to be very sure that this patient has reflux. And if you want to be completely sure, ambulatory pH monitoring is important. Then sometimes a patient has only chest pain, no other symptoms. And there is a dilemma whether this is because of GERD or whether it is or not, because there's no response, not a good response to PPI trial. In these cases, you may again do. So for atypical symptoms, sometimes when you're not sure whether they are due to GERD, you may go ahead with the ambulatory pH monitoring, especially if, for example, if the patient has hoarseness of voice. You're not sure. Even after a PPI trial, they haven't improved. So whether to look for other causes or whether this is because of GERD. So then in these cases, you would definitely do ambulatory pH monitoring. Then manometry. Manometry is done in, first of all, as I mentioned earlier, for placing the pH probe. Then any patient who goes for anti-reflux surgery. Anti-reflux surgery is when there is the fundus is wrapped around the lower end of the esophagus. Now, when this wrapping takes place, it can, in some cases, cause dysphagia also, because there's a too tight a wrap. And if the patient doesn't have a good peristaltic function in the esophagus, the patient has a high chance of dysphagia. So you have to see that the patient has a good peristaltic function in the esophagus before you go for an anti-reflux surgery. Secondly, manometry is useful to exclude other major motor disorders as an alternative diagnosis to GERD. So what are the other associated conditions of GERD? Pregnancy. 50 to 80% of pregnant patients will have GERD at some point of time. And the relationship between NSAIDs and GERD again is controversial, whether they can cause GERD or not. Then what is the relationship between H. pylori and GERD? So H. pylori, basically initially it was said that once you treat H. pylori, your chances of GERD increase. And that happens if you have what we call as corpus gastritis due to H. pylori. But if you have antral gastritis due to H. pylori, this does not happen. So do you treat patients of H. pylori positive if they have GERD? Yes, you will treat them if there is a good enough indication for treating H. pylori. And what is a good enough indication? One thing is the patient has ulcer disease. So if there is an ulcer disease and if the patient has H. pylori along with GERD, H. pylori positive along with GERD, you would treat that H. pylori. Then other associated conditions are scleroderma, because scleroderma affects the esophageal musculature. So it can cause poor peristaltic function of the esophagus. Then the LES hypotension it can cause, so that can promote GERD. Sjogren's syndrome is dryness. So dryness means lack of saliva. Lack of saliva means you cannot neutralize the acid which comes up. So that is why more chances of GERD. Zollinger-Ellison syndrome is again increased acidity. What is increased HI? So what are the other comorbidities? So almost 87.5% of GERD patients have documented comorbidities, and hypertension is one of the most frequent amongst them. Comorbidities are prevalent in both patients with NERD as well as esophagitis. And why is it important? Because basically hypertension and GERD, both of them are lifestyle diseases, and therefore they are seen more often together. Then other things are depression, anxiety, and sleep disorders are seen more likely in patients who are GERD. And depression and anxiety increases the occurrence and severity of the retrosternal pain and heartburn also. So both ways it works. Then GERD shares the same risk factors with hypertension and obesity, male sex, and alcohol drinking. And that is why this connection is there between GERD and hypertension. So GERD is present in almost 50% of patients with CAD. And a higher prevalence of GERD and CAD has been reported in elders, smokers, and patients with excessive abdominal fat. Then asthma. The prevalence of GERD in asthma patients is ranged from 25% to 80%. And I have already mentioned that this could be because of the reflux or because of reflex. Then 75% of patients with diabetes will have GI symptoms, and 25% have symptoms of heartburn, acid regurgitation or GERD. And many of the GI symptoms with diabetes are associated with the complications of diabetes like neuropathy and poor glycemic control. Then GRD and constipation. GI disorders is closely associated with GRD. The GI disorders meaning constipation. Patients with constipation often report GRD symptoms. And GRD and dyspepsia have been reported to be complicated by constipation. So how would you treat a patient with GERD? So what are the treatment goals? One thing is you have to eliminate the symptoms, heal the esophagitis, prevent or manage any complications, and once the patient is in remission, you have to maintain the remission. So you have what we call as lifestyle changes, then you have medical therapy, and finally the last resort is surgery and other endoscopic measures. Now the other endoscopic measures are not as yet mainstream and they are done more as a research this thing, but they will definitely come. So what are the dietary and lifestyle modifications? So basically avoid food and drugs which lower the lower esophageal sphincter pressure, like chocolates, any fatty foods like fried foods, etc., spicy foods, coffee, carbonated beverages. So these are all to be avoided. Then drugs which are again important, as I mentioned already to you, calcium channel block. Other important drugs are theophylline. This can promote. Then cigarettes and alcohol I've already mentioned. In hormones, progesterone. That is why pregnancy promotes GERD. Then anything which retards the gastric emptying time, like high fat meals and smoking, again promotes GERD. And whenever anything causes a mucosal damage to the esophagus, that can also give rise to symptoms of GERD. So what are the various non-prescription therapies? One thing is the head of bed elevation. So this can be done by either putting extra pillows, or your head of the bed is lifted up by putting a block beneath the head end of the bed. Or nowadays you get what is called as a reflux pillow. It is available on Amazon. So reflux pillow where the patient can comfortably sleep, because a lot of patients are uncomfortable sleeping with two pillows, etc. So this is, it keeps the patient like this. That means his half body is like this and legs are like this. So that is the head of reflux pillow. Avoid tight fitting garments, because again that promotes reflux. Then causing weight loss, because as I mentioned, obesity is linked to reflux. And dietary modifications, we've already mentioned what all to be avoided. Then restriction of alcohol and smoking is again very, very important. That has to be stressed enough. Then avoid food 3 hours before bedtime. And then chewing gum or oral lozenges. Why is it important? Because chewing gum or oral lozenges will promote salivation, and saliva can neutralize the acid if it comes up. Pharmacotherapy, you have various agents. One thing is antacids. Antacids are short-term agent you give for on an SOS basis. If you have symptom heartburn, say once in a month or something, it can improve with antacid. Then H2 receptor antagonists can be used again in milder symptoms, in higher symptoms which are major. It is difficult to control them with just H2 receptor antagonists. The mainstay remains proton pump inhibitors. And we will come to that in detail later. So I'm not talking too much about them now. Then you have other surface agents and alginates. Surface agents like say cipralfate, it coats the esophageal mucosa and keeps it safe. And alginates, basically, it covers the stomach bubble, and therefore it prevents the reflux of the acid into the esophagus. And prokinetic agents, which again tighten the esophageal sphincter or promote that gastric emptying. So these are the various things, but we will be talking, it is not possible to cover everything. So we'll be talking mainly on proton pump inhibitors. As I mentioned already, antacids are mainly for rapid action, short duration. But though they are very safe, they can cause diarrhea, hypermagnesemia, hypercalcemia, and alkalosis. Now, H2 receptor antagonists, the ones which are available with us are ranitidine and famotidine. But the PPIs are definitely faster, and therefore we use them more often. H2 receptor antagonists also have a slower onset of action. But H2 receptor antagonists are useful as nighttime dose in refractory GERD. That means if a patient you give twice a day PPIs, and yet the patient is not improving, then a bedtime H2 receptor antagonist for the nighttime acid reflux. Then we come to PPIs. So this is basically PPIs, proton pump inhibitors. So, whom will you use proton pump inhibitors? Patients who have failed H2R receptor antagonist therapy. Then patients who have erosive esophagitis, you should not try H2RAs, etc. You should directly go in for PPIs. And if the patient is again more severe symptoms, again directly go for PPIs. Normally, the standard dose is once daily for 8 weeks. But very often this may not work and you may need twice a daily dose. And subsequently, you can bring it down to low dose PPIs or H2RAs also. Then surface agents, I have already mentioned about this, so I will not talk about this now. So what is refractory GERD? What happens? What do you do once you have refractory GERD? The patient does not respond to twice a day PPI therapy for 8 weeks. You should confirm the diagnosis of GERD, whether the patient is having GERD or is it some other diagnosis. Check if the patient is complying properly with the dosage. Check the adherence to lifestyle modification. Add the nighttime H2 receptor antagonist, and then you go ahead with esophageal pH and impedance testing studies. This is just a short thing on, before we go on to the PPIs, about the surgical therapy, you give it only in patients with severe refractory GERD, and other reasons for operative management could include non-compliance or very severe esophagitis by endoscopy, benign stricture, Barrett's esophagus, etc. So now let us come to the PPIs. The treatment with PPI over treatment with H2R, ACG recommends treatment with PPI rather than H2RAs. Now, another important thing which I want to stress here, that PPI should be administered 30 to 60 minutes prior to meal rather than at bedtime or on after a meal, because it is the bioavailability will otherwise suffer. And PPI should be administered in the lowest dose in patients who require maintenance therapy. And maintenance PPI therapy indefinitely or anti-reflux surgery for patients with Los Angeles grade B and C and D is required. Now, as I've already mentioned, PPI improves the healing rate and there are fewer relapses in patients with erosive esophagitis. So how do the PPIs act? They act by inactivating the hydrogen potassium ATPase pump, which is present in the parietal cells. It should be taken once daily in the morning and evening for day and nighttime symptoms. And long-term PPI would be required in patients with severe esophagitis, that is grade C or D, patients who have developed Barrett's esophagus or peptic strictures. And long-term means could be over months or years. So let us talk about one of the PPIs now, that is rabeprazole, which is a multifaceted PPI, and it inactivates the hydrogen potassium ATPase pump. It causes, it is very, its efficacy and safety is established in non-erosive GERD, and healing and maintenance also has been seen with rabeprazole. So the usual dosage of rabeprazole is 20 milligram per day. And but the duration would be, for example, in duodenal ulcer disease for 4 weeks, gastric ulcer for 6 weeks, and for GERD is 8 weeks. So let us talk about some cases. This is a case of a 47-year-old man with a 4-year history of recurrent retrosternal burning pain and difficulty in swallowing also while eating. But there has been no weight loss. And on clinical findings, upper GI endoscopy shows ulcerating esophagitis. The biopsy urease test was negative for H. pylori. And biopsies from the gastroesophageal junction showed no metaplasia, that is no Barrett's esophagus. So ranitidine initially was prescribed, but there was a piece of steak which is caught at the level of the xiphisternum, and he was later prescribed with rabeprazole. And this patient's symptoms improved completely. In fact, dysphagia improves very fast in patients if you give the patients PPI. And if there is no stricture or a web, and it's only esophagitis, it can improve very fast. Now, the second scenario is a 60-year-old woman with a chief complaint of nocturnal heartburn. and experienced burning sensation behind her sternum. She was on OTC, over-the-counter therapy, for relief of her symptoms, which could be antacids, etc. She was moderately obese and there was slightly distended abdomen, but endoscopy revealed esophagitis, which is grade B, and therefore diagnosis of GERD was made. So here rabeprazole was initiated and she was asked to take once a day in the morning and to avoid large meals as they would distend her stomach. And she experienced best relief over many years. So rabeprazole is one of the most effective treatment options for GERD. So there have been a lot of trials comparing different PPIs, one over the other, and each trial has shown different results. So now we are talking about rabeprazole here, and rabeprazole here showed that in about 1800 patients who are enrolled, and rabeprazole 10 milligram or 20 milligram was given, and you would find that once daily the recurrence rate was 28%, while twice daily the recurrence rate was 9.7%. So you will find that twice daily has a much better response rate. So twice daily with rabeprazole improves the subjective symptoms as well as the health-related quality of life in patients with refractory esophagitis. Then this is another study where 73 patients were enrolled for rabeprazole 20 OD or 20 BD. So with a higher dose, improvement is definitely more in typical symptoms as well as in atypical symptoms. Again, this is just shown with more details of the symptoms. So a high dose rabeprazole is more effective for relieving typical GERD symptoms than the standard dose regimen. And again, this is another study in non-erosive GERD. 203 patients with moderately severe GERD were treated with rabeprazole 10 or 20 milligram compared with placebo. You find that it is definitely much better with the 20 milligram as compared to the 10 as compared to placebo. Again, this is just showing that the improvement in symptoms, etc., is much more with a 20 milligram dose as compared to the 10 milligram or the placebo. So rabeprazole reliably relieves GI symptoms equally well in both non-erosive and erosive GERD. So now you have some comparative analysis where here comparison of rabeprazole with pantoprazole, rabeprazole 20 and pantoprazole 40, and a greater percentage of patients showed improvement in the pH. This is the same in this format. So oral rabeprazole inhibit acid output to a greater extent but for a longer period than pantoprazole. So this is the measurement of acid output. Then this is again 52 patients where they were given placebo and then rabeprazole and then pantoprazole, and we find for how long the intragastric pH remained more than 4. So you will find with rabeprazole the symptom improvement was seen in 51%, with pantoprazole 42%, and nighttime in rabeprazole was 32% and pantoprazole was 17%. So in GRD patients with nocturnal heartburn, rabeprazole 20 milligram was more effective than pantoprazole. Now this is comparison with esomeprazole. This is rabeprazole 10 versus esomeprazole 20. Here again, day and night symptoms, you can see 98% with rabeprazole, 81% with esomeprazole, and 24-hour symptom-free interval, 8.5 days with rabeprazole and 9 days with esomeprazole. But here I must tell you that this dose which they are using, rabeprazole 10 and esomeprazole 20, is not a standard dose. Standard dose is 20 of rabeprazole and 40 of esomeprazole. So this is again in a graphic format where you're comparing rabeprazole versus esomeprazole in non-erosive GERD. So here it is shown that once daily therapy with rabeprazole 10 milligram or esomeprazole 20 milligram produces improvement in the majority of NERD patients. NERD are non-erosive reflux. Now here again, comparing of rabeprazole with esomeprazole, pain reduction from 4.43 2.5 with rabeprazole, and with esomeprazole it is from 4.43 to 0.83. The symptom score basically at start, at 4 weeks, and at 8 weeks. So it has better efficacy in mild to moderate GERD compared to esomeprazole. Now this is comparison with omeprazole. Then again here 227 patients enrolled, rabeprazole 20 and omeprazole 20 were compared. The healing rates were identical in both the groups at 91%, but numerically greater symptom relief was seen in the rabeprazole group. So this is nighttime severity grades of patients with improvement of symptoms and resolution. 82% of the rabeprazole for improvement versus 79%. So rabeprazole provides more consistent and occasionally significantly superior symptom improvement than omeprazole. So now let us come to trials that use combination of drugs. We have these drug combinations available with us, rabeprazole with domperidone. So if rabeprazole and domperidone taken for 4 weeks caused a significant and remarkable improvement in symptoms of GERD. So it not only provided desired relief of symptoms, but is also very well tolerated. And therefore it improves the quality of life of patients. So the score, that is the symptom index score, from 19 to 2.5. It comes down from 19 to 2.5 and from 12 to 0.3. So again, this is improvement in the symptoms. So fixed drug combination of rabeprazole and domperidone significantly improves reflux symptoms and was found to be safe and well tolerated. Again, this is comparison of efficacy of monotherapy versus fixed drug combination. And you find that the fixed drug combination definitely does better. So better choice for improvement of symptoms of reflux. So GRD, so to conclude, GRD is a reflux of some stomach contents, causes troublesome symptoms and complications. PPI is the most efficacious treatment for symptom resolution and esophageal healing. And rabeprazole is indicated in GERD and peptic ulcer disease in association with H. pylori eradication. And fixed drug combination of rabeprazole and domperidone significantly improve reflux symptoms. And it is a safe and efficacious medication for acid suppression therapy. Thank you.
Thank you, Dr. Molina. Excellent presentation, excellent cases, and good inputs. And now we will take both the faculties with later on after the completion of Dr. Ketan Mehta's talk. And the question answers, we have received n number of questions, and we'll take it later on. To talk to you about the Professor Dr. Ketan Mehta is difficult for me because we've been working together for so long. And at every IMA branch level, state level, and headquarter level, he has been a dynamic figure in taking lectures. That is definitely he's a professor from Medical College, KM, Somaya Medical College, and subsequently also professorship awarded at the IMA headquarters. He's a MD Medicine and other faculties. He has presented lectures, professors at various levels. He has held the post as President IMA Mumbai West. Now he'll be taking over as a Vice President IMA Maharashtra State. He has also been a President of the Academy of Advanced Medical Education, ME. Also, he is a web editor for Malad. He also actively participated in various committees at various state levels and other medical associations. And in fact, last was the organizing secretary of Golden Jubilee ASICON 22 held in Mumbai. So I think that much, if I start giving more details, it can be my lecture rather than Dr. Ketan Mehta. So I would request Dr. Ketan to begin his talk, and you can have your presentation. Over to you, Dr. Ketan. Ketan, you're not audible.
Okay. Are my slides visible now?
No, sir, so you'll
No,
have to share
slides are
your
not visible,
screen.
Ketan. Restart, restart.
Okay.
Slides, you restart.
Huh.
Yeah,
Okay. Visible, sir?
Visible now,
yeah,
sir.
full screen. Make
Okay.
it full screen.
Yeah. Okay. Thank you. So thank you, Dr. Lele, for those kind words, and a very good afternoon to one and all for attending today's special webinar on GERD. As Madam Molina Khanna has taken a very beautifully overview of GERD, the comorbid conditions, diagnosis, and modality, which has been very well covered. I would be proceeding further in the same continuum into that. So before I go, I wish you all a very happy Ganesh festival, which I'm sure our city is celebrating. Day after is the last day. Our country is gaining a lot of pride. We have already got 14 medals at the ongoing Asian matches which is happening in China. We already got a 3 gold medals, and that is definitely a matter for pride of us. So I would be discussing further on safety of proton pump inhibitors in different patient profiles. Madam has very beautifully covered about the different modalities of treatment, including non-pharmacological treatment, lifestyle modalities, and the therapeutic modalities which is offered. And over a period of time, we know the proton pump inhibitors have become the number one therapy in this segment of management of gastroesophageal reflux disease. So as we know that the PPIs are there and we have been using it for almost 2.5 decades, they are invaluable, safe and effective agent. It very effectively manages GERD and uncomplicated as well as complicated peptic ulcer disease. And all of us, be it from a family physician to consultant to super specialist, all are relying on this class of drugs for its wonderful effects also. Briefly talking about which I'm sure all of you know about the pharmacokinetic properties of PPIs, and Madam had given a just brief overview also about it. The various compounds available are omeprazole, esomeprazole, lansoprazole, dexlansoprazole, pantoprazole, and rabiprazole. And if you look at the differences, there are certain differences are there, whether we talk about the half-life of the molecule or whether we talk about the bioavailability of the molecules. Most of them have got a primary excretion metabolism through hepatic route, and the half-life, which is the longest, if you really see, will be slightly more for rabiprazole compared to other PPIs also. Now, I am going to discuss about when we use these PPIs in a different comorbid conditions. So here's something interesting data which we found about PPIs in diabetes. And what has been found that there is surprisingly some effect on glycemic control of in a diabetic population when they are on proton pump inhibitors. Now, how does this happen? The gastrin improves the glucose tolerance by the promotion of pancreatic beta cells, necroneogenesis, and that is one thing which would be definitely one point which will be there. Second is PPI itself elevates the serum gastrin levels, and then there are beneficial effects of PPI on glycemic control via the elevation of serum gastrin level. So PPI have the potential for a new approach in the treatment of diabetes. Friends, that doesn't mean that you are going to use PPIs for control of diabetes. Okay, that's not the point over here. Now, as I mentioned, that this PPI will improve the glycemic control by the basic mechanism is increasing serum gastrin, stimulating beta cell neogenesis, and raising serum insulin levels also. Now, is there a data on it? Yes. So this is the data which shows that effect of PPI use on glycemic control in patients with type 2 diabetes mellitus. So what it had shown over here is that the patients taking PPI had a significantly lower baseline HbA1c than those who were not, and the follow-up HbA1c was also significantly lower in those on PPI therapy. You can see the difference with those who were on control versus those who were on PPIs. So we could see there is a change in A1C level which was observed over here. So the when it comes to the possible mechanisms, so besides the gastrin increase, is there any other mechanisms? Yes, there are a lot of mechanisms which has been speculated. So there are certain unknown mechanisms by gastrin independent. And what happens is there could be an increase in beta cell mass leading to stimulation of insulin secretion, and then there could be an interaction with other hormones such as ghrelin, which also can be a effect. There could be a direct or indirect vagal nerve effect of gastrin in central nervous system, and there could be a gastrin mediated promotion of GLP-1 secretion by L cells in intestine. So there could be various other mechanisms by which the glycemic control can be achieved when somebody is on PPI also. Now, coming to other subset of chronic obstructive pulmonary disease, Madam mentioned about asthma and COPD. So we know that prevalence of GERD in patients of COPD is higher than that in the normal population. GERD causes acute exacerbation of COPD, and it is an independent risk factor for COPD death. And COPD and GERD are mutually causal, forming a vicious circle which can affect the quality of life. So COPD patients are again more predisposed to GERD, and the GERD patients are again having a poor outcome in a COPD patients. Now, PPI therapy for patients with COPD complicated with GERD clinical outcomes. Now, what is there any data on that? Yes. So this is one
Then
study.
slides,
Doctor,
slides, slides, slides not seen.
Okay. Can you see it now?
yeah, they are visible.
Okay, fine. Sorry for the technical edge. So now this is another data where effectiveness of PPI is in COPD, and this is a meta-analysis of various randomized controlled trial. And what does it show over here? These are the randomized controlled trial related to PPI in a treatment of patients with a definite diagnosis of COPD who were enrolled, and this complied with the Prisma 2020 guideline for this study also. So what were the results over here? So what was found that the PPI plus conventional treatment was superior to conventional treatment, and PPI treatment for COPD reduced the case fatality rate, reduced the incidence of GI bleeding, other adverse reactions, and number of acute exacerbations. So what was concluded at the end of this meta-analysis, that PPI therapy has significant effects on patients with COPD, in reducing the number of acute attacks, adverse reactions, and mortality. So overall, you are getting a benefit in terms of morbidity as well as mortality benefit in a COPD patients if they are on PPI concomitantly, and that is something which is we are looking at it. Now, how does this happen? How what exactly can be a more beneficial happen? So, pulmonary microaspiration of gastric acid is thought to be a possible cause of COPD exacerbations, which we know it's one of the mechanism, and therefore, if the gastric acid secretion can be reduced, it can lead to reduction in COPD exacerbation. So, giving PPI to people with COPD, you will reduce the frequency of COPD exacerbation and you will improve the overall quality of life. Now, the data which was I was saying, and then there is a nationwide population-based study was also conducted, which included almost close to 3,500 patients with COPD and symptomatic GERD, and the primary endpoint was to look at the acute exacerbation and mortality. And what was the result? Results, it had shown that the use of PPI was associated with a lower risk of acute exacerbation and mortality, and symptomatic GERD was associated with, of course, acute exacerbation, and if you control that symptoms, you are going to be beneficial. So use of PPI was associated with the low risk of exacerbation and mortality in patients with COPD and concomitant symptomatic GERD. Now, similarly, now talking about asthma, of course, we know the COPD and asthma, the mechanisms are there, though pathophysiologies are different. Madam already spoke about asthma, and we need to see over here that what is the effect of or efficacy of PPIs for the treatment of asthma in adult. As stated, gastroesophageal reflux disease occurs frequently among patients with asthma, and the PPI therapy can result in statistically significant improvement in morning PEFR, that is peak expiratory flow rate. So that is something which is that we ask our patients to monitor their pulmonary health by checking the peak expiratory flow rate, peak flow meter which are available, and on that parameter itself it can be checked over here. So a literature search was undertaken using the Medline, PubMed, Embase, and Cochrane review, and there were randomized placebo-controlled trials evaluating the efficacy of PPI in treatment of asthma in adults were selected. And obviously, the primary outcome of interest was to look at the morning peak expiratory flow rate. As I told you, that is the one simple parameter which can monitor the progression of asthma or worsening of asthma can be decided on that basis. And what was found that overall patients had a higher mean morning peak expiratory flow rate after treatment with PPIs compared with placebo. And then the subgroup analysis also revealed that there is a trend towards large improvement in morning PEF rate. So if they are continued with this over a period of time, they will see a significant improvement morning peak expiratory flow rate. So the conclusion derived out of this was that PPI therapy in adults with asthma can result in a small, statistically significant improvement in the morning peak expiratory flow rate, which is there. Now, coming to certain other issues, the safety of PPIs, which has been discussed time and again, and people are little skeptical about the potential PPI associated adverse effects. So let me tell you, the lot of analysis was done on that, lot of observational studies which has been found, and then there were a few randomized control trial. So one of the adverse effect which was thought about the kidney disease. Sometimes our nephrology friends just tell, they look at the list and they said, oh, this gentleman or this lady is on PPI, and that could be the reason. But mind you, these are only observational studies, and the quality of evidence is very low. So we cannot correlate that this is all happening because of the PPIs. Second is the one of the adverse effect talked about is dementia. Again, these are only observational studies only, so quality of evidence is very low. Bone fracture, which also has been talked about, again these are from observational study only, so the quality of evidence is low to very low. And of course there was data which showed that there is increased incidence of myocardial infarction. Again, these are observational studies and the quality of evidence is very low, so we don't have any concrete RCTs or any concrete meta-analysis which has shown that there is a significant adverse effect of the PPIs are there. So now, as Madam has already talked about the rabiprazole, its efficacy, the superiority. Now let us look at the safety of rabiprazole in different patient profiles also. So talking about rabiprazole in cardiac patients also. So of course the suppression of gastric acid production, by rabiprazole, as like any other PPIs, it will do the gastric acid suppression. Now it has shown to improve the stress test results in coronary artery disease patients. Now this is something interesting. Now, if you look at the data, the GERD is present in 60 to 85% of coronary artery disease patients. So, you have this concomitant or comorbid conditions presenting together. So, CAD and GERD often coexist. Again, Madam has already said that because of the similar risk factors such as advanced age, obesity, smoking. Now, vagal cardioesophageal reflex activation by acid reflux into the esophagus may decrease the myocardial perfusion or increase the myocardial oxygen demand, which is there. So this was the study to estimate the effect of gastric acid output suppression with rabiprazole on the course of angina pectoris and results of the treadmill stress test in patients with CAD. Of course, it was a small patient population, around 34 patients with stable angina were included, and stress tests were performed at the beginning of the study. Then add-on rabiprazole therapy, that is 20 milligram BID, was given, and again it was done. And what was found, that rabiprazole therapy significantly improved the outcome of the stress test, and it prolonged the mean stress exercise time, total exercise time, and the time taken to maximum ST interval depression also changed. So there was a significant decrease in ST interval depression, what we called is delta, which is the difference at the beginning and difference in the end, was significantly changed. And what it showed was the prolongation of exercise duration after the 2 weeks of therapy with rabiprazole in a patients with clinical amelioration of symptoms of coronary artery disease. So same subject, when they're taken at the study, and after 2 weeks, once you repeat it, the exercise duration definitely had shown an improvement. And also the exercise duration to maximal ST interval depression, that is the change when we call it somebody who is having a positive stress test. So the duration at which those changes appeared also changed with the 2 weeks of therapy with rabiprazole also. And this is what I was just mentioning about the delta of maximal interval depression before and after 2 weeks of therapy, which is statistically significant, which was there. So what was concluded out of this was that rabiprazole improved stress test results in CAD patients. So that doesn't mean that you are going to treat your CAD patients only with rabiprazole, but this is just an accidental finding which has been found. So it exerted a favorable effect on the frequency of angina-like chest pain, and which is like the treadmill stress test, it has shown a significant benefit. Now, this is another interesting finding, which was a study which was taken to assess the efficacy and safety of rabiprazole for peptic ulcer recurrence in patients on long-term low-dose aspirin therapy. So what was done is all those patients who are receiving long-term low-dose aspirin, we have our patients with underlying atherosclerotic cardiovascular disease, or be it from coronary artery disease, be it cerebrovascular disease, or be it peripheral arterial disease. Those who are on low-dose aspirin, which is 81 to 100 milligram per day, they were being evaluated, and subject were segregated in three groups. So one group received rabiprazole 10 milligram once daily, second group received rabiprazole 5 milligram once daily, and the third group received teprenuine 50 milligram three times per day. And what was found that cumulative recurrence rate of peptic ulcers over 24 weeks in 10 and 5 milligram rabiprazole groups were 1.4 and 2.4 respectively, so which is lower than the comparative arm. And bleeding ulcers were not observed in this even 10 or 5 milligram of rabiprazole group. So rabiprazole was well tolerated both the doses. Now imagine 5 milligram and 10 milligram, that is the dosage which are given. So the least possible dose which is used, and it was found to be beneficial. So it was concluded that rabiprazole 5 and 10 milligram are efficacious in preventing ulcer recurrence in subjects with a history of ulcers currently taking low dose aspirin for CV protection. So the drug is well tolerated at both the doses. So I'm sure, friends, you come across such situation where somebody is on aspirin, develops severe gastritis, develops ulcers. You sometimes you may have to discontinue, but you have to restart at some point of time any of the antiplatelet agents, and then at that point of time, under the cover of PPIs like rabiprazole, it will have a better effect also. Now let's look at the role of rabiprazole in asthma patients also. So rabiprazole also improves ventilatory function in patients with asthma associated with GE reflux. So the treatment of GE reflux with PPI improves symptoms of asthma in some patients. Again, this is a small study. 53 patients who were treated with rabiprazole 20 milligram daily for 8 weeks, and they were monitored for improvement in the ventilatory function also. So what was the results? That all the patients with the gastroesophageal reflux, they noted their improvement in reflux symptoms with PPI treatment. That is but obvious. An improvement of more than 20% in peak expiratory flow rate was observed in 8 of those 21 patients, and factors predictive of improvement in peak expiratory flow with rabiprazole therapy were the Quest score. So this is on that basis, and the steroid dependency of asthma. So that is what we found out. So, ventilatory function test and a Quest score during rabiprazole therapy in asthmatics with or without gastroesophageal reflux, and you will see that there is definitely a significant change which has been found in those subset of patients. So, what was concluded from the study that treatment with rabiprazole is expected to ameliorate asthma in non-steroid dependent patients who have symptomatic gastroesophageal reflux disease defined by the Quest score. Now, after asthma, let's look at now rabiprazole in COPD patients also. So, rabiprazole promotes vascular repair and resolution of sepsis-induced inflammatory lung injury, and this is happening through HIF1 alpha. Rabiprazole, we know, is a well tolerated, can enhance the vascular repair, and the treatment has resulted in reduction in lung vascular leakage, edema, neutrophil sequestration, and pro-inflammatory cytokine expression during the repair phase. So it will help in the faster healing, or what we call vascular repair, in those subset of patients. And now coming to rabiprazole in a diabetic patients population. Now, as we discussed earlier, clinically about 15 to 30% of patients they experience gastrointestinal side effects during metformin therapy, which is Madam mentioned about doxycycline amongst the one of the drugs which is notorious. Now, in anti-diabetic segment, metformin is the one drug which can cause such symptoms also. So, rabiprazole was described to treat gastrointestinal disease, particularly, of course, GERD, and the co-administration of rabiprazole and metformin frequently occurred. We know quite often our patients are on combination of rabiprazole and metformin. So this study was undertaken that are proton pump inhibitors a new anti-diabetic drug, what we just discussed in the beginning. So the study to investigate the effect of PPI on glycemic control in type 2 diabetic patients, and around 100 patients were recruited. So they compared the HbA1c level of those who were taking PPIs and those who were not. And what was found that HbA1c was significantly lower in individuals who took PPIs. And the people who used PPI with some type of insulin therapy had a HbA1c reduction by 0.8%. So, for the rest of the subgroup analysis, based on various anti-diabetic drugs used, the PPI consumption persistently exhibited lower A1C levels. So that means, irrespective of the anti-diabetic medications were used, the concomitant use of PPI had shown lower HbA1c. So probably, if the European Association of Study of Diabetes or American Diabetic Association will come out in the future as the new therapy in the management of diabetes, it would not be surprising if we are seeing such results also. So the conclusion of this study was that PPI is consistently associated with a lesser glycemic control in type 2 diabetes, and A1C reduction observed, which was similar to incretin based therapies like how we use the gliptins also. So, ladies and gentlemen, to summarize, the PPIs have the potential to be candidates for a new approach to the treatment of diabetes. Rabiprazole improved the stress test results in CAD patients. Rabiprazole is efficacious in preventing ulcer recurrence in those taking low dose aspirin for CV protection. Rabiprazole treatment ameliorates the asthma in patients who have symptomatic gastroesophageal reflux, and which we know a large population are having that. And overall, rabiprazole is well tolerated and enhances vascular repair and the resolution of inflammatory lung injury. So, thank you so much for your patient hearing, and of course, we would be happy to take up the questions if you have any. Thank you so much.
Yeah, thank you, Ketan. You exit from the presentation, so it will be on the platform now. I think we have a lot of questions I have received. Dr. Molina Khanna is also there, and Dr. Ketan also is there. First of all, let me thank both the faculties for giving the really great insight on the various PPIs, diagnostic, and of course comorbid conditions and other things together. So we will go. There are some questions in the chat box. I think some important questions we will tackle. I think the first question, Dr. Molina, is that how do we measure lower esophageal symptom? I mean, say, sphincter pressure, and can it be used to monitor GERD? This is the one question. So I think you can tackle that question.
Yeah, so lower esophageal sphincter pressure is measured by doing the esophageal manometry test. And I would like to mention here that less than 10% of patients of GERD have a lower LES pressure. So majority of our patients are going to have a normal LES pressure, and therefore there's not much of a point in monitoring it. And it is done only for certain situations, like as I said, if you want to keep the pH probe above the LES pressure in that situation, but not to monitor the reflux.
Which imaging studies is useful in the workup of gastroesophageal refluxes? Key points you can mention.
What are the
Imaging studies is
imaging
useful
studies?
in the workup. Yeah, imaging studies. Yeah.
So imaging studies actually are not really very useful in the diagnosis. You may pick up hiatus hernia on a CT scan, but otherwise you would not see in many imaging studies. Barium swallow again is not a very good investigation because you cannot pick up the nuances of low degree of esophagitis on a barium swallow. So it is used only in specific conditions like there is a dysphagia, etc. The most important investigation remains the endoscopy.
I think this question I had only put up, which of course you both can answer this. Advice on sleeping patterns, especially you. I think you mentioned in your talk that we do advise the sleeping pattern to the like, especially for the snoring people or those who have a GRD or hiatus hernia. So, any particular sleeping pattern can be advised to the patients of GERD and or especially those who get night pain, and we advise them certain measures. So, whether this is useful. Ketan?
Huh. Yes, sir. So, as Madam has already mentioned about it, so that is the one of the lifestyle modification what is strongly been recommended about. One is they should not even go to sleep for at least 2 hours after the meal. So whether they take afternoon nap or night time also, they have been asked to take early dinner so that after they finish the dinner, minimum 2 hours of gap should be there. That is one. Second is those who have a persistent symptoms, they prefer to take a little inclined positioning at even while lying down, and they are little more comfortable. So maybe at 30-degree also, which would be better positioning. And the third thing is, as you rightly mentioned also, that if they have an additional component of obstructive sleep apnea, which is, from the history, if it is suspected, polysomnography or a sleep study needs to be done on that, because there has been found that there is, of course, the patients with OSA, that is obstructive sleep apnea, and GERD, the concomitantly also coexist also. And if you have to take symptoms for it, obviously the correction of OSA also becomes a important aspect at that point of time. Thank you.
The second thing is whether the right lateral or left lateral, to facilitate the gastric emptying time. Is there any relation or any particular this thing is the attention is being done for the gastric emptying time?
So people have tried. In fact, this is what we gave from the patient's feedback, that I feel comfortable sleeping in these lateral positions or anything. But the best thing is avoid sleeping for 2 hours, and then they can sleep in whichever positions it is there. So it is all the most thing is what happens in the city like metro cities in Mumbai, where people have a dinner at 10:30, 11 o'clock, and by 11:30 they are off to bed, and that also causes. In fact, there is a data which is with the rural urban pattern, that in urban cities we have seen the increased prevalence of the GERD because of this type of pattern. Thank you.
So, Molina, when is the surgery indicated for GERD treatment?
Yeah, so the indications for surgery are what we call as refractory GERD. They do not respond to your treatment of a full dose of PPIs, which is twice a day. And along with that, you give them H2 receptor antagonists, the full lifestyle modifications. So in these patients, one would definitely confirm the diagnosis of GERD, and if it is confirmed, and then you can go ahead and plan surgery. The other thing is sometimes if the patient needs to continue PPIs for a very long period of time, like some patients with grade B, C, D esophagitis, you cannot stop the PPIs in them at all. So in some of these patients would not want to go on long-term medication So such patients, you may advocate surgery.
Second question, I think this is for Ketan. The rabiprazole is a very less has a drug interactive reaction. That's what compared to other PPIs. I don't know. You may have to mention it and whether it is a safest of the lot and another thing whether it is safe in the pregnancy also because in the pregnancy we find lot of acid burns and complaints of the gas belching, bloating. So which will be a safer to use in the pregnancy.
Okay. Again, a very good question. So the drug-drug interactions, what we seeking, because most of the PPIs has got a hepatic metabolism and CYP2C. That is the mechanism by which the drug gets cleared, and all the drugs which has got a hepatic metabolism can have minimal effects also, but these are not something which is significant. So the with all the PPIs, including rabiprazole, that is not a matter of concern at all. That is one. Second thing is talking about safety in pregnancies. Now there has been data about the safety of PPIs in pregnancy. In fact, one of the reference which is mentioned about omeprazole, which is been quoted as a relatively more safer because of its available data. Maybe because omeprazole was a much older drug which were been found, and obviously you have got a more long-term data. That is why it is there. But of course, people are still using it. But again, in unless it is really indicated for first trimester, we would prefer to avoid unless. So it is not a contraindication, but at the same time, it would not be a clear approval for using the PPIs in pregnancy, though it has been used very widely, especially when it come to first trimester. Madam, your views on that?
Yeah, I agree with you completely that omeprazole being the longest available drug, that this omeprazole definitely, if you have to give, that is the one drug which I would give. Secondly, I would prefer to give locally acting drugs like antacids, which do not get absorbed, antacids, sucralfate, and other lifestyle measures. And before I would go on to the drugs.
Right.
Dr. Molina, one more question, which is regarding the capsule endoscopy. As you mentioned, the diagnostic portion, capsule endoscopy is now available in Mumbai and some parts, and some people have started using it. Of course, it's a costly affair, and it is right now. I would say that it is very few people are using it. But what will be the really outcome and the use of capsule endoscopy to avoid somebody doesn't want to put in a scope? Then whether for the GERD diagnostic, whether it will be helpful.
Yeah, so capsule endoscopy right now, what we have and which is predominantly used is used for small intestine because
Correct.
you have good investigative modalities for large intestine and the upper gastrointestinal tract. Basically, because the possibility of biopsy is not there with capsule endoscopy, which you can get with a routine endoscopy, which is an upper GI or a colonoscopy. So as of now, there is no role of capsule endoscopy for the diagnosis of GERD. So it is mainly used if you are suspecting any small intestinal disease, any GI bleeds, where you've ruled out bleeds from the upper tract and the lower tract, and occult GI bleeds and things like that.
Yeah. Another thing was that you both are practicing in the hospitals, and it is probably most of the hospital setup. It is a common time that some PPI is added depending on the various that particular hospital gastroenterologist attached or a physician attached. So, what will be the choice of the in a patient who is admitted, and whether it is necessary or is it a must to add the PPI in every patient? Yeah, both of you, please answer that.
I would just add one point over there. So before a patient gets admitted, be it in Karuna Hospital, Suvarna Hospital, or Suchak Hospital, before me or Madam Molina Khanna sees the patient, our resident doctor feels the patient is admitted with deficiency of either rabiprazole or pantoprazole, and this is the first thing to give it, be it anything. So that is by default. I think the thing which they will write is that either which of one of them which is written, and before even we go, that one thing is given. Probably we get informed about our admission after that has been done. So it is, I don't think by default it will be ever we would be writing those, but it has already been there on board before it is given, because somehow that pattern, they have that point probably cultivated. They are coming with deficiency of pantoprazole and rabiprazole in the body. Madam,
Yeah, so yeah, you're very true. That is one of the first drugs which are added by the RMOs. But I definitely would give these drugs in patients who have indications like, for example, if there is a bleed or if there is abdominal pain, or if sometimes in very seriously ill patients also to prevent erosions, you give them. But not in all and sundry, definitely. Sometimes I also remove the medication if it is not required and it is not indicated. As to the choice of drug, which Dr. Jayesh has asked, I think there is not much to choose between any of the prazoles or any of the PPIs. I think most of the PPIs, both oral and IV, work equally well. Of course, sometimes what happens, one doesn't work in one patient and then you can shift to another one. That is possible. But otherwise, I don't think there's much to choose.
right. So that's a very valid reason. And secondly, even for a stress-induced ulcers, as Madam was saying, because so often we see that usage of sucralfate, which has been for prevention of stress ulcers, especially in the patients who are on ventilatory support or patients who are critically ill and all with multi-organ. So there where we definitely need to use. So we really need to rationalize.
Ketan, you're freezed.
I think it's network issue.
Yeah. I think Dr. Molina, only last small question: how to diagnose laryngopharyngeal reflux? Which is closely associated. Ketan, yeah. One common question: how to diagnose laryngopharyngeal reflux disease? Basically very closely associated. So I think you both of this. This will be the last question.
So,
Yeah.
yeah, but we don't call it as this is a laryngopharyngeal reflux. So there is nothing antity. So basically, the reflux, what happens sometimes the patient start aspirating. What happens is the micro aspirations because of the gastroesophageal reflux disease. When they aspirate and goes into the respiratory tract, and that is when they presents with chronic bouts of cough. So basically, I suppose that is what they want to ask, that predominantly it is a diagnosis by on the clinical judgment only, that if they are want to really ask that, if they are asking, but there is no such entity as laryngopharyngeal reflux. Madam,
Yeah, so basically, laryngitis is one of the uncommon atypical symptoms, and probably that is because of the reflux from the pharynx into the larynx, and the patient could present with the hoarseness of voice. And the only way to diagnose this would be doing a laryngoscopy to see whether there is inflammation around the larynx. That's all.
Thank you, Dr. Molina and Dr. Ketan. Excellent presentations, excellent discussion. And I would invite Dr. Manish Verma from, Dr. Manish, over to you, and then followed by Dr. Rashmi for vote of time. Oh, yeah, over to Manish.
Yeah, hi. Thank you, sir. Thank you, Dr. Ketan. Thank you, Dr. Molina, and thank you, Dr. Jayesh. It was a wonderful insight. Lots of information has been provided. It's such a topic that we see in everyday life, but still, so many insights have been provided, which I'm sure will help all the doctors in their daily practice. With this, I just pass on to Aman to say a vote of thanks.
So, well, with this, we have come to the end of this very educative and interactive session. I'm sure the audience would have gained a lot from today's discussion. A big vote of thanks to Dr. Jayesh Dilli, Dr. Ketan Mehta, Dr. Molina Khanna, Dr. Rashmi Mehta, and Dr. Shobha Ahuja for sparing their valuable time and being with us. So, thank you once again.
Thank
Yeah,
you
Dr.
all.
Rashmi.
Thank
Yeah.
IMA for the opportunity.
Thank you.
Dr.
Thank
Mani.
you. We have had an excellent discussion on GERD and the use of PPI with various comorbidities. I would like to thank our speakers for today, Dr. Molina Khanna and Dr. Ketan Mehta, for their great insights on GERD and valuable inputs in the question and answer session. I would like to thank Dr. Lele sir for moderating the session so well and helping the delegates in clearing their doubts as well as arranging this CME in the first place. President Dr. Shobha Ahuja Madam has always been a big help and support. I would like to thank Dr. Manish Verma and Dr. Gulshan for their help in arranging the CME. And a big thanks to the audience for attending in such large numbers. IMA Mumbai West is always proud to hold CMEs for our delegates, and our Mumbai West speakers are always ready to help clearing all doubts for our members. Thank you very much.
Thank you. Thank
Thank
you.
you.
Thank you, everybody.
Thank you.
Rahul, we can stop the stream now.